If you've ever given birth to a baby, you know that it's an incredibly painful thing. Well, there's one elimination disorder that patients relate to the same type and intensity of pain as giving birth, and that's a kidney stone. Today, we're going to be talking about kidney stones, also known as urolithiasis. So grab a blank exemplar worksheet and your Davis text. I really want you in the text with me as we're going through this. We're going to be starting on page 1477, and here we go. So kidney stones are calcifications or little blockages that happen anywhere within the urinary tract, oftentimes in the ureters, the urethra, the bladder, or the kidneys. And these little guys can cause a lot of pain. About 12 in every 10,000 people will experience a kidney stone. A lot of times we'll see this in the summer months or in southern regions because dehydration is one of those risk factors for kidney stones. Other risk factors include family history, and we'll see this in industrialized countries. Why? Because patients who have a higher intake of animal protein often have higher risk for having kidney stones. So what is a kidney stone? Well, it's a microscopic crystals that clump together to cause a stone or a calculus. And these stones can get lodged anywhere in the urinary tract, in the kidney, in the uteropelvic junction, in the ureter itself, or even in the bladder. And these can cause a lot of pain as they're in the urinary tract. And we're talking severe pain, like it looks like they're birthing a baby kind of pain. And depending on where that renal calculi is stuck, you're going to see the pain in different areas. Flank pain, meaning along one side of the back, lower abdominal pain or pelvic pain, depending on where that stone is lodged. You're also going to see gross hematuria. Gross not meaning yucky, gross meaning obvious. So you can see the blood in the urine. Kidney stones are frequently diagnosed with a CAT scan. A CAT scan is a non-invasive radiology study, kind of like an X-ray on steroids. It creates about 64 different slices of a picture of a 3D image of the patient's abdomen. And we were able to visualize the stone in the urinary tract and also see if there's hydronephrosis. Hydronephrosis means swelling, hydro, of the kidneys, nephron. So hydronephrosis is one of those things you can see in a CAT scan. Now we might order a KUB X-ray, but they're not going to show all different kinds of stones, so it's not a common way to diagnose. And then patients who are pregnant or are children, we may order an ultrasound to reduce the amount of exposure to radiation for those patients. Now, the good news is most stones, about 50%, are going to pass on their own, as long as they're less than 5 millimeters in diameter. So the name of the game is pain control. Remember, the pain is not going to go away until the stone is removed or passed. So go ahead and, get an order for pain medication around the clock rather than as needed to really stay on top of that pain. So pain control is number one. We can use narcotics or NSAIDs. Narcotics being those controlled substances like morphine, and NSAIDs like ketorolac and ibuprofen. Ketorolac is kind of like the bigger buffer cousin of Motrin or ibuprofen. And those are really nice at reducing pain. In fact, they found that NSAIDs are equally as effective as those narcotics for pain control. We can also give antiemetics for controlling the nausea that often is associated with kidney stones. And then look, we can also give those alpha adrenergic blockers like tamsulosin, the same ones we give for BPH, to help open up the urinary tract and help that stone pass more freely. Now, for those larger stones that are not going to pass on their own, we can have surgical management options like a ureteroscopy or an extracorporeal shockwave lithotripsy. Let's take a look at those. So this ureteroscopy is when the urologist actually takes a camera scope and goes up through the urethra and is able to collect that stone and then remove it like that. The percutaneous nephrolithotomy is the same kind of thing, except the scope is directly inserted through the skin, through an incision in the skin, rather than up through the urethra. And then sometimes we can use this ESWL shockwave treatment where ultrasound shock waves are actually sent through the skin, and that helps break up those big stones. And then the stones are able to be passed through the normal elimination tract. Now, some complications that can arise from kidney stones. Remember, a kidney stone is an obstruction of the urinary tract, and those stones aren't smooth on the edges. They're gritty and rough, and so they can cause injuries to the urinary tract itself. And anytime we have urine that is unable to be passed, we're going to have urine festering in the urinary tract, and it's going to create the likelihood for infections and injury to the kidneys. And so pyelonephritis is a kidney infection. Urosepsis means a urinary tract infection that overwhelms the body and becomes a septic situation. And we can also see acute kidney injury that ends up being irreversible kidney damage, as the urine that's being made in the kidneys is unable to pass out of those kidneys due to the obstruction. So let's go ahead and go through the nursing process as usual, talking through the ADPI process. When we're assessing for people with kidney stones, we're going to see severe pain. We're probably going to see some severe pain manifest even in their vital signs. We want to look for tachycardia, tachypnea, those manifestations of severe pain. We might even see a fever if we're worried that this has become an infectious process. We're going to see pain, and it could be a colicky pain, meaning the pain comes and goes as that stone kind of shifts in the urinary tract. So the pain is going to come and go, and it's going to be severe, likely in the flank or in the lower abdomen or the pelvis. We're going to see nausea and vomiting. And we may see more acidic urine as some types of stones are able to breed in acidic environments. So our nursing diagnoses, or the problems that we are going to address as nurses, are going to be problems involving acute pain due to the inflammation and the obstruction of the kidney, altered elimination due to the obstruction, and the risk for infection due to the obstructed stone that's causing festering urine to stay in the bladder or even into the kidney itself. So here's what we do. We administer medications as ordered, especially as it relates to pain and nausea. We maintain a high fluid status, 3 to 4 liters every day. We want to flush those stones through the urinary tract. We're going to strain all of their urine, and it comes with these little urinary strainers. It's a funnel with a mesh strainer at the bottom, because we need to catch those stones and send them to the lab to determine what kind of stones they are, so that we can prevent those patients from having them in the future. And finally, we may need to insert a Foley catheter if we're concerned about the ability for the patient to pass urine. Because remember, urinary retention can cause acute and even lasting injury to the kidneys. So let's talk about teaching. Let's talk about teaching during a kidney stone episode versus after. We're going to teach our patients to push fluids 3 to 4 liters a day, to stay mobile, because that mobility can help shift that kidney stone through the urinary tract. We're going to teach our patients to strain their own urine and keep and save any stones that they do pass. And certainly to call the provider for fevers, chills, nausea, vomiting, or uncontrolled pain. You know, way back in the 60s and 70s, we would have admitted people for 5-6 days to pass their kidney stones. But a lot of patients with kidney stones, depending on the size of them, are able to stay home with pain medication and nausea medication rather than be admitted to the hospital. And then we have some other teaching we need to do once the stone is passed, because kidney stones can reoccur, and a patient who's had them before is now at higher risk for getting them again. So we need to teach kidney stone prevention. We need to teach some diet modifications, like a low sodium diet, to increase citric acid intake, like lemons or lemonade. Many stones are going to not grow in an acidic environment. We need to encourage patients to decrease oxalate intake, things like coffee, nuts, chocolate, or tea. Ooh, that's a hard pill to swallow, isn't it? Coffee and chocolate and tea all out of your diet. Oof. And then we need to avoid purines, those animal meats that can increase the amount of animal protein in one's diet. Beer, pork, red meats, and seafood all have purines in them. And then after the kidney stone episode is over, we still need to encourage the patients to have a pretty high level of fluid intake each day to keep their urinary tract flushed. So once the episode is over, we're talking about anywhere from 1 to 2 liters per day for PO fluid intake. So how do we know if the nursing interventions we did work? Well, hopefully for patients who had stones and no longer do, we're going to help them prevent the formation of future stones. We're going to see that their preservation of kidney function. Remember, those labs that involved kidney function are the BUN and creatinine. Those are going to indicate good renal function. So we're going to see normal levels in their creatinine and their BUN. We're going to see a patient who's free of pain. That's a great thing. We're going to see a patient who's afebrile because they didn't develop a UTI as a consequence of this urinary obstruction. And we're going to see adequate amounts of clear yellow urine, which indicates that their elimination is normal and that they're able to pass their urine. If you've ever seen a patient suffering from a kidney stone, it's not a pretty sight. It's very uncomfortable. It's our job to provide that pain medication, provide nausea medication, and teach patients how they can make lifestyle modifications so hopefully it doesn't happen in the future. Thanks for listening, and I'll see you next time.